There we go. Okay. Sign-ins going around, and we're going to talk about joints and articulations today. We're going to wrap up everything on bones and structures and stuff like that. So let me show you. I was mentioning this in lecture today. Let me go into bone box. No, it's not a movie. No, and you're not buying a box of bones. Here it is. This is the bone box. It's been around for a long, long time, at least as long as I've been here. And I've been here 18 years. I'll send you the link through eLearn, but this lets you look at all the different bones in the body that are on the list, and shows you like the vertebrae. There's the atlas and all the points of the atlas, and you can quiz yourself on these. And there's the axis, like number 7, it'll ask you spinous process, or there's number 1, the odontoid process or the dens, transverse process. Let's pick a typical, like number 1 should be the body of the vertebrae. There's a superior articular surface right there. There's the spinous process right there. If we look at the scapula, we have the ventral surface, and we can look at, there's number 6, thank you, would be the glenoid cavity. Here is number 7 is going to be the coracoid. Number 8 is the acromion. So this is a nice little easy way to test yourself. I'll send you the link through eLearn so you can click on it. Because if you type in bone box, like I did, it used to be you type in bone box and go right to it. It was bone box at the University of Chicago, but that's all changed. So the link is a lot longer now. So, but it's a great little easy way to review for your bone test. It covers a lot of the material. You also should have gotten those lists I sent out to you a couple weeks ago that listed all the bones of the skull, all the bones of the appendicular and axial skeleton, I hope. And I think I sent some practice that you could drawings that you could fill in on the parts. So if you haven't seen them, go back and check your emails, because it was a couple weeks ago. Okay, now let's get into, there we are. Let's go to joints and articulations in here. And I want to go to, there we go. Let's get to the that. So, okay, joints and articulations. Bones are going to move on bones. That is articulation. When a bone rubs or moves on a bone, and we have movement, we have a joint. And some of our joints are going to be freely movable, some are going to be slightly movable, and some don't move at all. So we base our joint on 2 classifications. Do they move, Are they a freely movable joint like our knee, doing stuff like that? Or is it an immovable joint like the sutures of our skull? Is it a slightly movable joint like we have at the pubic symphysis? So we can classify our bones by movement and also by structure. What kind of structure are they made of? Are they going to be a cartilaginous joint? Are they going to be a fibrous joint? Or are they going to be what we call a synovial joint? You know, a cartilaginous joint would be like this. Again, the pubic symphysis, because there's cartilage in here. The joints between the vertebrae are cartilaginous joints. A fibrous joint are like the sutures, because there are little fibers that hold the bones together. And a synovial joint is a capsule joint filled with fluid that separates all of our long bones so that we have that flexibility. So in articulation, anywhere where we have two bones coming together, movement can occur in three different ways. They can't move at all. They're immovable. We don't want the bones of our skull to be moving around. We don't like that. So the sutures in our skull, let me go get the skull over here. The sutures, where the skull comes together, don't move. They are immovable. They have no flexibility. They used to when we were still growing, but these sutures are going to be immovable. So we don't see any kind of movement there. So we get this. This is a suture. We know what a suture line is. This is a suture line is an immovable joint. Now, if we want to look at one that's slightly movable, we take a close look at the pubic symphysis. It doesn't move at all, or very, very little. It does have some flexibility to it because we have to absorb shock, just like the pads between the vertebrae. They're slightly movable. They have a little bit of give to them, but you know, the fully movable are the ones like in our fingers, when our fingers move around, or when we have our knee. This is a, you know, freely movable. We don't have strings attached, but it is a freely movable joint also. So we have, you know, the categories here then are going to be based on, are they, what, you know, if we're looking at movement, what kind of movement do they have? Slightly freely movable, slightly movable, or immovable. Term for these: synarthrotic, amphiarthrotic, and diarthrotic. You can see the root word of arthritis in there too, because you see arthrotic. So we see the root word arthrotic means and deals with movement. Synarthrotic doesn't move. The sutures in the skull, the mental symphysis, that structure right in the middle of our mandible, the teeth in our sockets are synarthrotic because our teeth are embedded in our tooth socket, and then there's a ligament called the periodontal ligament that holds our tooth in place. And if you've ever had a tooth extracted, one of the things you may hear your dentist say to you, because you're not going to feel any pain, but you're going to feel a lot of pressure. Of course, if you're appropriately numbed up, you shouldn't feel any pain. But the pressure to lever that tooth out of the socket takes a great deal of pressure because there's a ligament there, a periodontal ligament holding that tooth in place. Our first what we call the costosternal joint on our sternum, where we have rib number 1. That is an immovable joint. Also, it's a synarthrotic joint. The amphiarthrotic joints, the slightly movables, are the discs, the rest of the ribs, and the pubic symphysis. Anywhere we have a little bit of movement is a slightly movable joint or amphiarthrotic. And the third category are the freely movables, the diarthrotic joints, the shoulder, the knee, the hip, the elbow, the fingers, that's the interphalangeals, the fingers and toes, the tarsal bones in your foot, and the carpal bones in your wrist. Those are all freely movable joints. Now, for testing purposes, you just need to remember no movement, little movement, and freely movement. I'm not going to make you have to remember those terms. If you want to, that's fine. You know, synarthrotic, amphiarthrotic, or diarthrotic. But most of us say slightly movable, freely movable, or not movable. Because then you don't have to stop and think, well, what's that word mean again? You know, so, okay. An immovable joint. The bones are very close together. They have connective tissue holding them in place. You know, like the teeth in our sockets have a periodontal ligament. Now, this is one of those places where normally we don't like to have bones real close together because of the friction that occurs if they rub. But here, where they're not going to move at all, we don't care if they're butted up against each other. And that's the case in the suture, in the skull. That's the case with our teeth in the socket. They're butted up against each other and they're not going anywhere. So there's not going to be any friction. We don't get friction in our mouth when we use our teeth, because our teeth aren't going to rub up against the mandible or the maxilla. Classic example of the immovable joint are the sutures. Now, the other term here, we have what's known as a syndesmosis and a gomphosis. The gomphosis is the term for the teeth in our socket. Okay, so. And that is again, that's going to be, our teeth in the socket should be an immovable joint. If you have a patient whose teeth are loose, you know, there's a lot of things that are causing that. Some sort of periodontal disease, gingivitis, inflammation of the gum, something damaging the bone, something destroying the bone. Any number of things can be causing those teeth to be loose in their socket. The ligament has been damaged, whatever. Teeth should not normally be loose. Healthy teeth shouldn't be loose in their socket. Something to always look at when you're dealing with your patients. Just like we shouldn't have excessive flexibility in the spinal column. Again, you know, we want to have freely movable joints like our fingers. We want to have slightly movable in our spinal column and immovable in our skull bones and in our teeth. We don't want to see the movement of our fingers be hindered. Consider that these should be freely movable joints that move with no pain, but if we have a lot of pain and discomfort and we can't move our fingers, you know, what it becomes is if it's hard, if it hurts to move your fingers, what are you going to do? If it hurts to move your fingers, what are you going to do? You're going to what? Go to the doctor, or don't move them. The first, you know, because you're ultimately right, but what we do is don't move. If it hurts to do something, we don't do it. And what will happen if it hurts to move our fingers, so we don't move them, they get worse. The cause of the pain in moving your fingers allows the fingers to become immobilized, and then it hurts more to move them. So if we ignore the problem it generally doesn't go away. And that's what we need to remind our patients in a very nice way, that you can't ignore a problem. Lots of people believe if they ignore it, it'll get better or it won't bother them. Well, you know, it happens. Okay, now the slightly movable joint, the amphiarthrotic joint. These are held together by hyaline cartilage or fibrocartilage. The immovable joints were held together with connective tissue. You know, the periodontal ligament in the mouth for the teeth, the fibers that connect across the skull, even at the suture line, there are fibers that interlace with one bone to another to hold that in place. Here we have a little bit of motion. There is cartilage involved, either hyaline cartilage or fibrocartilage. Hyaline cartilage shows up at the ribs. All these rib bones are attached to the sternum, either directly or indirectly through hyaline cartilage. It gives us some flexibility because our ribs have to expand. When the intercostal muscles, the muscles between the ribs contract, our ribs rise up. And when they rise up, the chest wall goes with it because the ribs are attached to the chest wall. And if the chest wall goes up, the lungs go up with them. So the lungs inflate. So these slightly movable joints here where the ribs attach to the sternum have to have some give to them. They have to have this slight amount of movement so the ribs can expand and relax. Same thing applies to the pubic symphysis. The pubic symphysis is not hyaline cartilage. The pubic symphysis is fibrocartilage, the same stuff that we've got between the vertebrae. So it's a little different. It's not as flexible as hyaline cartilage is. It's tougher, but it functions as a shock absorber. The shock of motion comes up the legs and goes up the sacroiliac joint in the back and gets absorbed here in the front by the pubic symphysis pad, the fibrocartilage pad. So we have a good example here of a slightly movable joint with fibrocartilage. The ribs give us that other example with the hyaline cartilage. And these terms here, the syndesmosis and the symphysis, well, we've heard symphysis, we mentioned the term, the pubic symphysis is that pad between the two pubic bones in the pelvic girdle. Now, another one though, in addition to the symphysis, is the syndesmosis. And we see this at the bottom of the leg. The example of the syndesmosis is the connection between the fibula and the tibia down at the ankle. Now remember, there is no ankle bone. The ankle is made up of the medial malleolus from the tibia and the lateral malleolus from the fibula. The medial malleolus is this structure here at the bottom of the tibia. It's on the medial side. You rub the bump at your ankle on the inside of your leg. That's the medial malleolus. If you rub the one on the outside, that's this structure here. Lateral malleolus, that's the end of your fibula. It's the only thing the fibula does for us is contribute to the structure of the ankle bone, or the ankle, there is no ankle bone, it's contribute to the structure of the ankle joint. Now, there's ligaments that hold this joint together. And notice how, the weak side generally tends to be on the fibula side, because the fibula is a pretty useless bone. It doesn't give us, it's not load bearing, it doesn't give us a lot of support. Its primary role is to form the lateral malleolus to give us flexibility. But that's the side that when someone injures their ankle, it's nearly always going to be on the fibular side. Not 100%, but mostly. Okay. When we sprain our ankle, we either stretch or tear the ligaments that hold the joint together. The ankle joint, made up of the callus from the tarsomus. Remember, the talus is the bone that sticks up. You've got at the foot, you've got the there's a foot right here. The talus is the bone that sticks up. The calcaneus is our heel. The calcaneus extends behind us, sticks out at the back. The talus is the one that goes upright. This is the talus right here. And so the talus is surrounded on either side by the medial and lateral malleolus. See, if you look at the animation here, that this is the fibula. Fibula makes up the lateral malleolus. The talus is right inside of it, and the medial malleolus is on top of it. So we can here is a something like this. There's the medial malleolus. There's the talus. It sits on top, just like this. It forms the inside of the ankle structure. The outside is going to be where the fibula is. And you notice, see, you have those ligaments tear. They tear or they stretch. Something else you might notice is this other bone here in the back that sticks out of the back of this animation. This is the calcaneus, and this is the heel, and that's the Achilles tendon connecting right there. So we'll talk about the Achilles tendon a little later on. But damage to the ankle generally is going to occur on the fibular side, on the side of the lateral malleolus, because that is the weaker side of our ankles. Okay, so there's our, so that was the syndesmosis. The symphysis, of course, is what I've showed you several times here. It is the fibrocartilage pads, either at the intervertebral disc or at the pubic symphysis. See where the green arrow is on the screen. Remember that fibrocartilage is soft tissue and does not show up on X-ray. We have a dark spot there to show us where the pad is, but we can't see the pad. X-ray does not do soft tissue, so we don't see it. We would need a CT or an MRI to get the soft tissue. But the fact that we can't see it still tells us it's there. Because there's a dark spot there, well, that's where it's supposed to be. Now, the intervertebral disc, that's fibrocartilage. Again, this is a symphysis type structure. And this leads us into the freely movable joints, the diarthrotic joints. Boy, I said a lot of stuff on that page. So what a freely movable joint is everything else. The arms and legs, fingers and toes, hands and feet, anything that can move around really well, the knee, the shoulder. These are all freely movable joints. The bones are covered with hyaline cartilage at their ends, like this femur. The head of the femur is covered with hyaline cartilage, and where it articulates into the acetabulum of the pelvic girdle, there's going to be more hyaline cartilage inside the acetabulum, so there's no friction when the bone moves. The same thing applies at our shoulder, where the head of the humerus articulates in the glenoid cavity. So we don't want to have any kind of friction. Now, to make this a little more complicated, we have the two ends, the two bones that are articulating, whether it's a socket or whether it is like the phalanges here in the foot, like for example right here, where the two bones come together. They're both going to have hyaline cartilage at their ends, so there's no friction, but there's also going to be a capsule surrounding each of these joints. This capsule is made out of connective tissue and filled with fluid. And we call it a synovial joint filled with synovial fluid. You may have heard the term synovial fluid. Synovial fluid is a lubricant. Our bones function in a fluid environment, so there is no friction when they're moving. They never, A healthy bone never touches the bone it's articulating with. So the synovial fluid, we keep making the synovial fluid, it lubricates the joint, and our bones can articulate all they want to, and it doesn't hurt. And so all of our fingers, all of our toes, all of our, like our elbow joint, our knee joint, our hip joint, our shoulder joint, are all going to be synovial joints, diarthrotic joints, freely movable joints, lubricated so there is no friction when we move. Now, if we look at them by structure, they can either be a fibrous joint, a cartilaginous joint, or a synovial joint. If it's a fibrous joint, it doesn't have a cavity. Well, most joints in our bodies don't have any kind of cavity. The only joints that have any kind of cavity are the freely movable, the diarthrotic, the synovial joints. They have a capsule that surrounds the ends of the bone. But fibrous joints don't have anything like that. They're simply held together by connective tissue. Again, we get back to the sutures. So a joint that doesn't move, an immovable joint, is also a fibrous joint. We have two bones that have butted up against each other and there's no movement whatsoever. They're frozen in place. They're going to have fibers that run back and forth across here. So a immovable joint is always going to be a fibrous joint, or just like a tooth in the socket. That's an immovable joint, but it also has the tooth held in place by the periodontal ligament, which is a fiber. Our teeth aren't supposed to move in their sockets. But fibrous joints can also have a little give to them. We see fibrous joints also taking place where the tibia and fibula come together at the ankle. We also see it where the radius and the ulna come together at the wrist. The radius and the ulna are going to articulate on the carpal bones at the end of the wrist, at the end of the arm, right at the wrist, and they are held in place by fibers. Now, there's a great deal of flexibility at that joint. We can do all sorts of things with our hands. We can maneuver our hands all the way around. There is a great deal of connective tissue fibers here holding everything together. And we get a lot of movement in here. But sometimes that movement backs up on us or hurts us. A lot of the ligaments and tendons involved in these fibers can become inflamed. Anybody ever hear of carpal tunnel? Carpal tunnel disorder is when the ligaments that are running right along in here, helping to connect the ulna and the radius to the carpal bones becomes inflamed, and it can cause a great deal of pain down the arm. It results from what we call repetitive motion. It's a repetitive motion injury. You do the same thing over and over and over again for hours at a time. You end up inflaming, causing inflammation to occur in these joints. In this joint here, it's a fibrous joint. You inflame the connective tissue, because that's what the carpal tunnel is, a structure that leads to the carpal bones. And so overuse of those fibers causes inflammation. A repetitive motion injury occurs when you're doing the same thing constantly at work. You see it a lot of times in some sort of factory settings where when I lived in Virginia years ago, there were a number of turkey processing plants in the county. And there were people there, their job was simply to stand there, and when a turkey carcass came down the line, they would go like that. That's all they did was they make one cut. The person next to them make another cut. They would just do this constantly. And many of them all developed carpal tunnel. They had to be switched to another job. You know, the treatment for carpal tunnel is to stop doing it or maybe even have surgery, but repetitive motion triggers it. You know, doing the same thing over and over and over again. You know, your job is to cut the neck off the turkey for 8 hours a day, 12 hours a day during peak seasons leading up to Thanksgiving, for example. So, or you're a painter, and all you do is use your roller every day like this. You know, a number of years ago, I painted the outside of my house, and used a roller like that. And I was doing it every day for about 3 weeks to get, you know, to put a couple coats on. At the end of the third week, I couldn't raise my arm past this because I had inflamed, you know, mildly inflamed tendons in here. And then eventually got better, but for a while there, it was like, oh, that hurts. You know? And so I didn't do it, but it still hurt. It's a common occurrence in here. These fibrous joints, if they're stretched, if they're inflamed, are going to hurt. Now, where do we see them? We see them at the end of the wrist. We see them at the end of the forearm, at the ulna and the radius, where they articulate with the carpal bones. We have to wrap that area with lots of connective tissue fiber to hold it together. I mean, sort of, not unlike what this looks like here, and that's at the elbow. Then of course the tibia and the fibula have lots of fibers holding that joint together. Because again, you know, there is very little articulation of these bones. Or there shouldn't, you know, we don't like to see these bones rub up against each other. And they don't like a lot of stress. So these fibers will hold the joint together, but they will tear or become inflamed. So let me go back here. Make sure I covered that. Okay. Fibrous joints. Okay. Connective tissue, whatever. Now, the cartilaginous joints. And so now we've gone from the immovable to the slightly movable. All of the joints that have cartilage in there have little movement. It's either fibrocartilage or hyaline cartilage, no cavities at all. Now we see this at the sternum. We see it at the pubic symphysis. We see it at the intervertebral disc. And something new, we see it in the long bones and what we call the epiphyseal plates. The epiphyseal plate is a growth area. Okay, so this is a long bone. Our growth areas are at this end and this end. Our bones grow outward this way and outward this way. And it's a remnant. When we were in utero, in our first 6 weeks after conception, we have a full skeleton in place, but it's made out of hyaline cartilage. So they're about that big. We have a full skeleton. The hyaline cartilage is going to be used as a model to lay down a full bony skeleton. And the areas of growth, by the time that we are in childhood, most of our skeleton has been converted to bone, except for these areas, these growth areas. The growth areas are still hyaline cartilage, and the hyaline cartilage grows and expands and then becomes calcified and turned to bone. So our growth plates are these epiphyseal plates here that are cartilaginous. They grow on each end, and they will do that until we're about 23 years of age. So there's the fibrous, the cartilaginous joint there in all of our ribs, for example. And we see the other cartilaginous joints are going to be here at the intervertebral discs. So now, comment about being double jointed. I probably said this already, but there is no such thing as being double jointed. Nobody's double jointed. All a person is double jointed has extra stretchy, is it a word? Whatever. Extremely stretchable, it's better, ligaments and capsules. So a person that we say is double jointed has extra flexibility, so they can do bizarre things. Like my son can take his fingers and bend down the first phalange, just like that. Yes, there you go. Thank you. Thank you. Can you do that? So, okay, sort of, yeah. Okay. Well, you know, but you're flexible. You know, it's that extra flexibility. You don't have extra joints. You're just extra flexible. But we say people are double jointed because they can do things like that. It doesn't hurt, and it's not going to cause problems later in life. Yeah. So, yeah, it just happens. Some people are like that. The capsules that surround the sockets around the joint, around the bones, are going to have extra give. Okay, now this is the epiphyseal plate right here. If we look at an X-ray of a child's femur and tibia, you can see a black line across there at the end of the femur and at the top of the tibia. That black line is there because that's where the hyaline cartilage is. Hyaline cartilage doesn't reflect X-ray. Hyaline cartilage is soft tissue. X-rays go right through. So all we see in the left side there is a dark line. That's the epiphyseal line. That's where growth is taking place, right here, both at the tibia and at the femur. This one's growing up and this one's growing down. This is where our long bone growth is going to occur at these epiphyseal lines. But once we get past about 23 years of age, the hyaline cartilage converts to bone and doesn't grow anymore. The hyaline cartilage disappears. And then all we get then is this line. We get a white line that occurs, and any X-ray can show you, if you have an X-ray of a leg or an arm or any long bone, you can see the scar, the epiphyseal line, where the growth was occurring. If you can see the dark line, if you can see the dark space, that's the epiphyseal plate, that's the growth plate. And if your patient is unconscious and you have X-rays and they're that sort of indeterminate appearance, where they could be anywhere from 18 to 25, at least if you have an X-ray of an injury, you'll be able to get a better guess as their age, if the plates have closed or if they're still open. So it's probably not going to alter how you're going to treat them, but at least it will give you an idea of their age. Okay. Now, this is the most common joint in our body. These are the synovial joints. These are the ones we like. These are the flexible joints. These are the freely movable joints. And if you look there, you can see, now these are two phalanges. We have a phalange, we have a finger bone on the top and one underneath it. And we have hyaline cartilage, highlighted here in blue, that surrounds each end of the bone so that they don't ever rub together. They come together like if I'm holding my hands together like this with my fists up and down. They're not rubbing together. There's a layer of hyaline cartilage here to protect that. Well, ideally, we would never even rub the hyaline cartilage together because that green band that you see represents a capsule that surrounds this joint. And within that capsule is fluid. And the fluid probably has the consistency of corn syrup. It's pretty thick. You know, it's like real heavyweight motor oil. You know, it's goopy, if you will. And it's a lubricating fluid. So the bone ends never touch. They never touch directly. And even if they were to touch accidentally, we still have the hyaline cartilage there to protect us from any kind of friction. See, this is ideal. The problem is, as we age, we lose some of our ability to produce this synovial fluid, this lubricating fluid. And gradually we have less and less of that synovial fluid in there, and then the bone ends start to rub together. And once the bone ends start to rub together, it hurts. And when it hurts, what do? We don't do it. And so our fingers or our shoulder or our knee, as we get older, causes problems. And we don't like to, we don't like to move our hands, or, we don't like to bend our knee or whatever's causing us trouble, because the joint has gotten weaker. So, and it's all because the synovial fluid isn't being manufactured as rapidly as it used to be. We can't keep up. And unfortunately, these bone ends will rub together. I mean, this is what, osteoarthritis is all about inflammation of our bones, of the bone ends are like that. 85% of us are going to develop arthritis at some point, osteoarthritis. So it's not like something we're going to, oh, that's not going to happen to me. Well, it's going to hit most of us. So depending on your individual's overall physical, health, their exercise levels, their diet, genetic makeup. We talked a little bit about genetic predispositions in lecture today, and all that's going to determine how well arthritis is going to affect them or not affect them. They may be lucky in that 15% that doesn't develop arthritis, or they may join the 85% that does have it. It depends a lot on health, their overall health, and their lifestyle. A person that is sedentary and doesn't move around a lot is more likely to develop. You would think someone who is very active would probably cause more wear and tear in their bones. That's not really the case. The more active a person is, the less likely they are to have arthritis as bad. An individual who is sedentary and doesn't move around a lot, the bones get used to not having to do a whole lot. And if it hurts, we don't do it. So anyway, so where do we see the synovial joints? The shoulder, the hip, the elbow, the knee, the bones of the wrist, the bones of the feet, the fingers, all of these structures here where we have the bones coming together, where we want to have free movement. Here we see what kind of motion we get. This is the shoulder is probably the most freely movable joint in our bodies, because, as I've said several times, we can almost rotate a full 365 degrees around the shoulder. We have to sort of cheat a little bit at the angle there, but we have pretty good flexibility at our shoulder, because the shoulder isn't much of a socket anyway. The glenoid cavity is a flat surface, but the ligaments and tendons and muscles that hold our shoulder together. Where's my shoulder? Here it is. This is our shoulder. Look at all the ligaments and tendons and muscles that have to come together to hold our shoulder in place, to give us the flexibility that we have here, or we have in reality. So, have a shoulder. Have a shoulder. Okay. So, now we can come back this way. So, we have a whole lot more flexibility than that. Don't hurt my shoulder. So. Okay. So, and this is not unusual, you know. Now, as your patient ages, the ability to do things like this may become less, you know, and it may not be the shoulder, it may be their pelvis. It may, you know, they may have pain in movement at the pelvis. They may have difficulty in bending over. It happens, you know, a lot depends on wear and tear too. So, okay. Synovial structures are going to have this capsule surrounding the joint, but they also have something else in here. They have, you know, first of all, at our knee, we have pads of cartilage to protect the joint. And the knee is sort of an outlier on the type of synovial joint. But here, if we take a look at our knee, we can see our pads of cartilage. Here's our knee. And if I pull the knee away, right here, these are called the meniscus here and here. And they are simply large, thick pads of cartilage that the femur rests on top of, so that when it articulates against the tibia, it doesn't cause any friction. So, you know, if you have a patient that has injured their knee, you know, and lots of people have done that, they've torn the cartilage in their knee. Well, they're talking about these pads of cartilage right here. You know, but the role they play is very, very important, because we don't want friction between the end of the femur and the head of the tibia, because that's going to hurt, and we don't like pain. So the first thing we use are, we have these menisci, whatever, where to keep bone from rubbing against bone. And it isn't just in the knee; we have it in our jaw. And we have it at where the sternum and the clavicle come together. So right there at that clavicular joint on the manubrium, we're going to have a meniscus here too. Now, something else we have, it's very common, are bursa sacs. A bursa sac is like a water balloon filled with synovial fluid. So imagine a water balloon filled with corn syrup, you know, if you could do such a thing, you know. But it would be this squishy, firm balloon that is, you know, it isn't like a balloon would break with it. This would be like a heavy rubbery surface with this fluid inside, and it would serve as a lubricant contained in the sac. So, and our bodies have these bursa sacs anywhere that bones and ligaments and tendons would rub together. We see it, if the picture at the top, the picture in the bottom, the top picture at the bottom, there we go. This is the acromion. Right here, this structure is the acromion. And this is the clavicle coming together. The clavicle and the acromion come together, and there's a bursa sac in there to prevent friction. It's just a bag of synovial fluid, and you can see it better on the there at the bottom, right there underneath, you know, underneath the clavicle, or on top of the clavicle, underneath the ligament. It's to keep the ligament from rubbing up against the clavicle. We have these bursa sacs all over the place. We have bursa sacs in our knees. We have bursa sacs, you know, not just in that part of the shoulder, but in other parts of the shoulder. Anywhere where bones or muscles and tendons and ligaments rub together. The carpal tunnel is a large bursa sac, and it becomes inflamed. The condition is known as bursitis. Here we see an MRI of the knee. From the side, you can see the femur and the tibia, and you can see the patella. And you can see the patellar tendon that's holding the patella in place. Now, the bursa sac is right in front of it. The bursa sac is this gray area right in front of the patella. Here's the patella. There's the end of the femur. There's the patella, our kneecap, right in front of the patella. This structure right here, right above the word says patellar tendon, that little dark structure, that is a bursa sac. And if that becomes inflamed, you can see on the right side picture that the bursa sac is inflamed and it has turned white because of all the inflammation, and that hurts. Individuals who have constant pressure on their patella are going to run this risk. People that in their occupations spend lots of time working on their hands and knees. Maybe you are you install floors. Maybe you're a painter. Maybe you're a mechanic. Maybe, who knows what you do, that you spend lots of time crawling around, you're installing wiring. You're an electrician. Maybe you're installing internet services, you have them come out and put in DirecTV, for example, or that you wire your house up for internet. I don't know why, because you only have to have a router now, but lots of occupations require you to put pressure on the patella. And when the patella becomes inflamed, it is very, very painful. Again, like I said, the whole carpal tunnel inflammation is caused by inflaming the tendon at the end of the ulna and the radius, and inflaming the bursa sac. So now this leads us to the most complex joint in our bodies. This is the knee. The knee is a hinge joint. Okay, that's good. It is not a complete synovial joint in that it doesn't have a complete capsule. It only has a complete capsule on the sides, the medial and lateral sides, and on the back, the posterior surface. There is no capsule on the front for the knee. The knee is actually three joints itself. It is the patella and the femur, and it's also the medial and lateral junction between the femur and the tibia. So these are two separate joints, one here and one here, where the medial and lateral sides of the tibia come together. And then there's a third joint where the patella and the femur come together, like in the model here. So we have three different joints, and it's a, as I said, it has a synovial capsule on the sides and on the back, but not in the front. Now, what does the knee do for us anyway? Well, among other things, the knee keeps the patellar tendon from rubbing up against the femur and causing irritation. The knee is also the point of attachment for the quadriceps muscles to keep them from rubbing up against the femur too. So the knee plays a very important role for us. It is still, the patella plays a very important role here. And here we can see there's our patella right in the front. The tendon is not shown here, but it will be in a second. There's our knee. Typical knee movement where you can flex our knee. It's a hinge joint, so we can bring our leg all the way back, so where our heel can touch our gluteus maximus, maybe. We can bend our leg forward, we can kick it out. We can't bend our knee inward, and we can't bend it the opposite direction. We can do it once, and we can't do it after that. Our bodies don't like that. Our bodies have a little flexibility from going side to side, and a little flexibility for going backwards, but not a lot. We can't bend our knee. We can't stress our knee outside some very narrow parameters, but bending it like this is perfect. That's what our knee is designed to do, is to bend. You know, and sometimes we hyperextend our knees. You know, in contact sports, how often have you seen somebody are playing on a muddy field and they put their foot down and they go to turn and make their move and everything goes except the lower leg because it's stuck in the mud or it's stuck on dry ground or it just happens because we can't control things like that. And there goes the knee and you damage the knee.
What's the pop you hear from that?
Oh, it's probably it could be the femur popping up off of the meniscus. It could be the patella popping out of place as it goes, you know, as it slides off to the side.
But I was getting my bed's really tall. I was getting on my bed, I use my knees, and then I turn. My knee didn't, and it hurt really bad. But like as I straightened my leg back out, there was the pop.
Yeah,
But no.
you know, and it's easy to push this ligament off to the side, but fortunately it does come back in place. That's probably the pop you heard.
Oh.
You know, did it hurt any the next day?
Not really. I
Yeah.
was sore for like an hour or so.
Yeah, and then that's because, you know, you were pushing it somewhere where it wasn't supposed to go, but it wasn't a permanent type of thing. Our bodies make funny noises like cracking your knuckles. You know, everybody knows that. You know, I think I told you before, that doesn't cause any permanent damage at all. It just makes your knuckles feel good, you know, because you're releasing air from that, the joint structure. Okay, now, there is our knee joint. As I said, the most complicated joint in our bodies. We bring together 3 bones, 4 if you count the fibula, because the patella is right in there. So let's take a look at some of this. Here is a ligament that we hear a lot about, the anterior cruciate ligament, the ACL. We hear about lots of people that have torn their ACL. Well, there's, you know, because the ACL helps hold the femur to the tibia. The ACL helps hold the femur to the tibia, and its counterpart is the posterior cruciate ligament. Because if you have an anterior, you're going to have a posterior. Now, why do we call it cruciate? Because cruciate is the old term for cross, and the anterior and the posterior cross over each other. So there's the patella. There is the patellar ligament. Now let me. And so we're going to take a look at the ACL right here. There's one of the menisci. There's the other meniscus there. And there's also 2 ligaments, one on either side, to help hold the tibia and the femur together too. So here we are, the ACL. It connects the front of the tibia in this groove, in the intercondylar groove, which is, let me show you where that groove is. The ACL, the anterior cruciate ligament, is going to connect right here. The groove is these are the condyles of the tibia, and the groove is right in here. And that's where the front of the ACL is. It connects there, and it also connects to the posterior surface of the lateral condyle of the femur. That's it, the way it was written there. So here we have our femur. Here's the medial condyle because it's on the same side as the head. Here's the lateral condyle. And so we have the medial side of the lateral condyle. That means the inside surface. Okay. Here's our lateral condyle. Here's our medial condyle. If it connects to the medial surface of the lateral condyle, it's that area right in here. So, and you can see it. Let me bring up my knee. Hopefully I can do this without tearing that. Okay, here's our knee. Here is our ACL. right here. Here's our ACL. Now, this is the ACL. Let me get back. Okay. Now, how do I know which side is lateral and medial? Well, there's a fibula down here, and the fibula is always on the lateral side. So this is the lateral condyle right here. This is the lateral surface of the lateral condyle. This is the medial surface. This is the anterior cruciate ligament here, where it starts on the femur. This is the femur up here, and it goes down to here. This is that groove right here between the condyles. So this is the ACL right here. Now on top of it is the PCL. The posterior cruciate ligament attaches in the opposite location. There we go. The PCL attaches to the back of that intercondylar area, on the posterior surface between the medial and lateral condyles, and attaches to the lateral side of the medial condyle. It gets confusing, doesn't it? So, here we go. Here's our PCL. Okay. Now I know that this is the medial condyle because it's because the fibula is over here. There's the fibula down here. Fibula is always on the lateral side. So that's got to make this the medial condyle. So there's our medial condyle. That's the medial surface of the medial condyle over here. That makes this the lateral surface. This is the PCL here, number 9, running down to the intercondylar surface, the area between the condyles and the tibia, but it's on the posterior end of it. That's why it goes to right here, down here. So anyway, they cross over, and we generally see the ACL is the one that gets torn more frequently than the PCL. It has I think it has a lot to do with the stresses applied to the knee. The ACL usually prevents us from hyperextending the knee, which is a very common occurrence. If we hyperextend the knee too far, we're going to tear the ACL. We don't want the tibia to slide forward. We don't want the knee to slide forward. Well, sometimes that happens, and we tear the ACL. The PCL would only get damaged if the tibia if the tibia goes back and the femur goes forward. So we hear more about ACL injuries than any other kind of knee. Well, tearing the meniscus is a common injury, but as far as the ACL goes, it's more common than the PCL. They can both be torn. They can both be damaged, but when you tear the ACL, you're tearing the ligament that attaches the front of the tibia to the back of the femur. Because really, what's going to hold that joint together? We've got those two ligaments. We have the patellar ligament, which attaches here. And then we've got these two ligaments on the sides. And that's about all that holds that joint together.
So if somebody has a knee replacement, is that basically because most of the tendons have degraded? Or?
No, it has to, and I'm glad you asked it because I'm getting ready to show that. But if you have a knee replacement, what you're doing is taking away bone that has degraded. The bone there's wear and tear in the bone. People that have, the ligaments tend to stay in place. But the bones have become worn, and it hurts to move because you're rubbing bone on bone. So, okay, so this is an ACL injury right there, showing you where the injury is occurring. It generally requires surgery to fix that. Now, there's our posterior surface of our knee, again showing us there's our fibula. So we know this is the medial side, that's the lateral side. This is the ACL right here, because it's rubbing up against the medial side of the lateral condyle. And then this is the PCL here, and you can see the meniscus, femur, PCL. This is the fibular ligament. And on the other side, there'll be a tibial ligament. There's the lateral meniscus, the fibula, the tibia, the medial meniscus, the tibial ligament, and then that was the medial condyle of the femur right here, and the lateral condyle of the femur here, and the medial and lateral condyles of the tibia. Patellar ligament holds the knee in place right there, and you can get a good shot of this fibular ligament. And there's the tibia, the fibula, and the ligament. The fibula doesn't even reach the femur. The only thing it does at its proximal end is help hold the femur in place with that ligament on the lateral side. There's our femur. Now, problems with the knees. This, I'm going to show you the knee replacement. We can dislocate the knee. We can pop it back in place. Probably require a certain amount of, may involve surgery, because again, it's a very complicated joint. It's not like the shoulder where you dislocate the shoulder, you pop the head of the humerus out of the glenoid cavity, and then you push it back in. So, okay, this is how we do a knee replacement. The condyles degrade and they become worn, and they're rubbing up against the condyles of the tibia. And so we have a great deal of friction there and a great deal of pain. So the treatment procedure is to shave off the inflamed and damaged tissue and replace both, replace the condyle, the meniscus pads on the tibia with an artificial knee. Well, it's a two-part process. We put in some sort of plastic pad in place of the meniscus, and then we have artificial condyles on the end of the, well, actually, we have artificial condyles on the end of the femur and on the end of the tibia, and we have an artificial meniscus in there. And this is what the condyles look like. This is the top part of an artificial knee. These are condyles that go on the end of the femur, just like they're going to show you here on the animation. We drill into the bone, put on the condyles for the tibia right there, and then we put the meniscus pads on top of that. There's the condyles for the femur that just went on. And then we reattach the patella. The ligaments are just pushed out of the way. The ligaments are not cut in here to do this. Everything, all of these can be just slid aside and or reattached. These medial and lateral ligaments here that attach to the femur can be attached a little higher on here. And so you get this great flexibility then like this. This is what we see. This is how we, with a complete knee replacement, we have takes out the tibial, takes out the worn bone on the tibia and the worn bone in the femur. And even if the bone wasn't worn on one side or the other, you'd have to take it out because now you're going to be rubbing it with this metal structure. And we don't like to do that. And your patient that has a knee replacement, it's like they just took off 20 years. They're mobile again. They're flexible again. Pair up a knee replacement with a hip replacement, and you've got some incredible flexibility in your patient now. So, and lots of older people have this done, and they get their full mobility back again. Most, there's always going to be the anomaly. We still keep the patella in place, held in place by the ligament. And you notice how we still have the patellar, the tibial and fibular ligaments here. If you don't remove, you can either reattach them to the bone or just take off enough of bone that's degraded so that the point of attachment for the ligaments isn't touched. It's as minimally invasive as you can make something like this be. Okay, now hip replacement. The hip replacement takes out the broken, you have two reasons to cause a hip replacement. You have broken the neck of the femur, or the head of the femur is so weakened by osteoporosis that it has no strength left to it. In either case, the procedure is simply to cut off the top of the femur, grind out the bone marrow in the middle, in the medullary cavity of the bone, and then insert an artificial hip in there. And this is, we use this is known as a bone rasp. It does have some sharp edges here, but it's a bone rasp, and you rough up the inside of the medullary cavity, and then you place this structure, the shaft, down in there. And then this becomes the new head of the femur. And it's usually covered with some sort of non-stick surface on there. That's stainless steel, but many of them are made of titanium. It's lighter than steel, but stronger. And there's usually, and then the acetabulum has to be replaced and covered with a new surface and a non-stick surface for the ball of the socket to rotate against. And so this is what we see. We see the stem and the head, the liner, and the acetabulum, because you can't do one without the other, because you have a stainless steel ball like that rubbing up against the bone, it's going to wear it away. So we replace it with, we replace both ends of it. And depending on how much of the femur is impacted, determines how much the femur is cut away. You can make a very, very high cut like that one. You can cut way down into the bone. Here we see one, this is our range of motion. It's pretty good here. Here we see one where even with this short cut where we're cutting, we leave part of the head behind, we go pretty far down into the shaft. Now, a couple things you can tell by looking at this X-ray is that our bones are supposed to be pretty, what we call radio opaque, meaning we're supposed to see a lot of calcium in the bone. The bone should show up as white, not quite as white as the artificial hip, but where we see a lot of shadows in our bone tells us where a lot of the calcium is gone. Like this other hip is probably a good candidate for replacement too, because there's not a lot of calcium present in there. There's a lot of calcium missing. So this side is probably going to break along here if it isn't fixed soon. And some people are happy and some aren't. So, but it's a very common procedure, the hip replacement. It used to be, as I think I said last time, that if grandma fell and broke her hip 40 years ago, they repair the hip and pin it back together again and hope the bone would grow, and put her in a body cast. And she more than likely died from pneumonia in a couple of weeks because she couldn't move around. Now grandma breaks her hip and they got a new hip in her the same day or the next day. And they got her up and around in a couple of days. In the hospital these days, you don't get to lay around and enjoy yourself. They get you moving pretty quickly. And if you have a hip fracture, you're up and around. Usually maybe the same day of surgery, but definitely the day after. And you're usually walking unassisted in 2 weeks. The first week it's usually a walker, second week is usually a cane. At the end of the third week, you're in without anything else, anything you need. So. Okay, and, oh, we can do it for the shoulder too. This is a socket for the head of the unit. So I'll show you that. These are all real structures too that I've had given to me over the years. So it try not to hit each other with them. Okay, and that's all I've got. Anybody have any questions? Okay, then let's get out of here.